Hey, good afternoon. It's John Snyder, another edition of Newton-Wellesley Medical Group Lunch and Learn, coming to you live from our TripAdvisor vaccine site here in Needham, Massachusetts. Today, we are going to give a record number 876 vaccines to 876 lucky people. So we're excited to be here, and we're also excited to have Doug Camo here to talk to us about sports-related concussions, a headbangers review. Next slide, Doug. So just teasing upcoming Lunch and Learns. Next week, we have Neeraj Kohli is going to be talking to us about incontinence, and followed by Dr. Garcia is going to be talking to us about epilepsy. And then we are going to be taking the school vacation week off, and then we'll have viral hepatitis part 2 with our chair of medicine, Larry Friedman. We want to remind folks that all our talks are recorded, and they're put up on YouTube just by searching Newton-Wellesley Medical Group. You'll get a whole index. We've also secured a spot on our intranet, Newton-Wellesley intranet, which is called Newton, and you can go ahead and get there by nwh.org/intranet. If you click down on learning resources, there's a lunch and learn section. So thank you to Jacqueline Kalelis for that. Next slide. We want to remind folks that Newton-Wellesley Orthopedic Walk-In is open. Hours of operation, Monday to Friday, 8 to 8. No appointment is needed. And on Saturday and Sunday as well, 8 to 1. Phone number is listed there. Doug does work in the same office there, so we thought we'd take the chance to kind of tell folks about this place. Next slide. And these are the services that we would typically be caring for. Any kind of injuries you'd see on a ball field. We have full x-ray capability there, as well as casting and bracing. Next slide. And then we have a bunch of physician wellness programs that we want to make sure people are aware of. You've heard me talk, I think, about all of these. Physician care concierge. This is where I tell people how I get all the great referrals for things that I don't want to do, like grout my tub. Weekly virtual meditation classes. Those are Thursday, 5:30. You can drop in on those. We are offering a Peloton 1-year free membership for any physician or APP on staff. That's 1 year free. Go ahead and sign up for that. You can contact Leland if you have not taken advantage of that. On top of that, Daniel Destin at the Shipley Fitness Center has a great team ready to do some free online coaching and physical training for you. And then lastly, there's a great virtual yoga class that's a drop-in, no reservation needed with Peter Kelly from the Shipley Fitness staff. That's Wednesdays, 5:15. Next slide. And without further ado, Doug, I've known Doug for many years, and I'm so glad to have him back. He's now lead physician over at Boston College, and he's also working with us at 978, and we're really happy to have such a great family doc and such a great sports medicine doc on staff. So go ahead, Doug. Thanks.
Thank you, John. So we're going to go through a crash course on sports-related concussion today, calling it a headbangers review. I do not have any disclosures at all for myself or my family. This is our sports medicine team at 978. We have Doctors Foster, Nascimento, Simon, Rogers, and myself, and specialize in sports medicine, shoulder, orthopedic surgery. For the others, I'm primary care sports medicine, also an osteopathic physician, do osteopathic manipulation, also concussion management as well, and any sports medicine needs. So today we're going to discuss concussion updates from the recent international conference, know an appropriate return to play progression, and then also identify newer strategies to assist in recovery. And we'll save questions for the end, just so we can make sure we get all the information out there. Rapid fire, we can talk about concussion for 2 or 3 hours, but we're going to do it in 15 to 20 minutes. So greater than 300,000 mild traumatic brain injuries occur annually, and it can happen in any sport. And there's a much higher risk in a game situation, whether it be at any level, than a practice situation, just because of the nature of competition. About 55 years ago, the history concussion was first defined by the Committee on Head Injury Nomenclature of the Congress of Neurological Surgeons. And the first definition of concussion was an immediate and transient impairment of neural functions, such as alteration of consciousness, disturbance of vision and equilibrium due to the brainstem involvement. So over the next 30 years, over 16 theories and return to play guidelines were published. So that was an issue. More so because pre-2001, there were 16 different grading scales, and then also too many opinions and return to play guidelines. So if somebody didn't like what the Cantu guidelines were, they could go follow somebody who did the Colorado guidelines versus the American Neurological Society guidelines. So really, in 2001, a lot of different international organizations, including sports medicine, neurosurgery, neurology, and even FIFA and other professional sports, decided to have International Concussion Conference to try to redefine sports concussion. So in 2001, they redefined sports concussions and abandoned these grading scales. So if you see something in the newspaper that someone suffered a grade 1, 2, or 3 concussion, that hasn't existed in theory since 2001, even though it's still in the paper today. 2005, some people really didn't like not having some type of scale, so they didn't change the definition of sports concussion, but they called concussions either simple or complex. Simple being a run-of-the-mill concussion in which you would have very little symptoms after the actual injury, complex being somebody with recurrent concussion or prolonged symptoms. And this is the conference that first mentioned post-concussion syndrome. In 2008, they said simple versus complex doesn't work, mainly because most simple concussions then became complex. So we decided to treat all concussions individually. And in this conference, they mandated neuropsychological testing for all concussions, which was a little difficult because in some states, there's only one neuropsychologist for the entire state. So it's very difficult from a sports medicine perspective to find a neuropsychologist for all concussions. They also formed the standardized concussion assessment tool version 2. It's mentioned exercise testing for post-concussion syndrome, which we're going to mention later on the talk. In 2013, the fourth international conference, they actually recommended the neuropsychologist, not mandating it. So it led to a lot reassurance amongst the sports med field. And they started to recommend vestibular rehabilitation and exercise for chronic concussion symptoms. Also updated the SCAT to a SCAT3 and a child SCAT3. We're going to talk about the SCAT5 today, which is the current version of it. So 2016 was the 5th International Conference on Concussion in Berlin. There is going to be an updated conference coming up this year from a paper standpoint, and we hope to update these definitions as well if needed. They changed the term and definition to sports-related concussion from initially concussion or mild traumatic brain injury. And that sports-related concussion is a traumatic brain injury induced by biomechanical forces. Several common features that may be utilized and clinically define the nature of the concussion head injury include: what is the mechanism of injury? Is it a direct blow of the head, neck, or body? Or is it just an impulsive force, such as like a whiplash injury where they have concussion symptoms? There could be a rapid onset of short-lived impairment of neurological function that resolves spontaneously. Signs and symptoms can evolve over minutes to hours or even days. Clinical signs and symptoms can be consistent with other comorbidities. So that could include substance abuse, cervical spine injury, vestibular dysfunction, or behavioral medicine conditions. And it also could result in neuropathological changes, but these changes are typically functional and not structural. So that's why you rarely see us ordering neuroimaging at first with concussion, because if something's more functional, not structural, there's no need for head CT or other imaging modalities unless somebody is decompensating. So signs and symptoms of sports-related concussion could be a variety, which could include one or more of the following. So symptoms can be somatic, cognitive, or emotional. Physical signs, i.e. loss of consciousness on the field, balance impairment, behavioral changes like irritability, and then they snap out of it after even a few minutes or hours. Cognitive impairment, also a sleep-wake disturbance in which they could be more drowsy or fatigued. All these signs and symptoms are not specific to concussion, but if an athlete does have that, or even a patient that's not an athlete does have that, concussion should be in the differential diagnosis. So one of the key points, any suspicion of head injury warrants removal from play. So when in doubt, hold them out. And you really want to have an appropriate time to be granted to the medical staff on the field or on the sideline to evaluate that patient at least 10 minutes to get a good, adequate examination. And there's really no perfect diagnostic test or marker for immediate diagnosis of sports-related concussion. Really, our sideline assessment is more of a rapid screen to see if somebody does have a concussion or concussion symptoms. So then we would immediately make the decision to pull them out of the match or game or practice or whatever the involvement would be, as opposed to a definitive diagnosis, which we would get post-game or at halftime. And so we're going to talk about SCAT5, which is the most comprehensive assessment tool for sideline management. And also you can use that in your office, and we use that in our office for concussion assessment as well. So the SCAT5 includes a symptom checklist that is preferably completed by the patient on paper. That will allow you to see how long it's taking them to fill it out, and then also how they rate themselves when they can focus on circling the symptoms. You want them to complete it in a resting state, so their heart rate is down to back to a normal heart rate as opposed to immediately after their head injury. CAT5 added a 10-word option for the standardized assessment of concussion, which includes immediate and delayed recall, and also it utilizes both the tandem gait and the best balance testing as opposed to one or the other. Other key take-home points is that the diagnostic utility of the complete CAT5 decreases significantly after 3 to 5 days, but the symptom checklist is validated as a measure for progress and healing in all stages of healing. So typically when we would see patients in follow-up for concussion in the office, we would do more of a symptom score, balance check, vestibular ocular screen, as opposed to doing the entire CAT5. But for the initial visit, the entire CAT5 would be performed. Baseline testing is useful, but not necessary. So just for people who have not seen the CAT5, I just did a little copy and paste on the pictures here. This is available if you want to Google British Journal of Sports Medicine CAT5. It's free to download the PDF if you want to read more into it. First slide here is all step 1, red flags, observable signs of something that's not a concussion. Maddox questions is really specific towards athletic care, where, what quarter are we in, what half are we in, who did we play last week, to see if those are typical questions that athletes would be able to answer. And if they can't, that's concerning. Glasgow Coma Scale we've all heard of and used it in other facets besides concussion management. Cervical spine assessment would be more so trying to see if they have neck tenderness to palpation or if there's any evidence of potential spinous process or transverse process fracture. The second most important part of the CAT5 is the athletic background. So student athletes that we have in high schools and colleges that we would cover, we know this history already, meaning how many head injuries have they had in the past? Do they have history of migraines or headaches that precede the diagnosis of concussion? Do they have ADHD or other learning disabilities? Do they have any other behavioral medicine condition? Have they been on any medications recently, or have they been have they changed their medication? All these things could prolong concussion length and time, so that's why it's good to know ahead of time. The most important part of the CAT5 is a symptom evaluation sheet, which is pictured here. So when you first evaluate a patient on the sideline, or in our case, we would do a sideline assessment, and then in the locker room where it's a quiet place, we want the severity of the symptoms that they have at that time. So if they have the worst headache of their life, it'd be a 6 because it's the most severe. Whereas in follow-up visits in our office, we actually do more of a frequency. So we say, hey, how long have you had, or how often have you had a headache in the past 24 hours? If they've had a headache for 24 hours, that'd still be a 6. But if they've only had a headache for 12 hours, it'd be a 3. So this symptom score sheet is important because you allow the bottom questions actually allow you to rate what percent they feel compared to 100% of their normal and why. In addition, it also allows them to rate whether they get symptoms with physical or cognitive activity. And then we would do typical orientation for the standardized assessment of concussion, place, time, date, recall. I like to use apple, cart, horse, water, bubble as my 5-word recall. But then when players are concussed multiple times, I have to change it up because they remember those words and they come in and just joke around and say apple, cart, horse, water, bubble. And then we would have them do that 3 times, repeat after me. Then we would do a numbers game in which we would say, we're going to reverse the numbers 1, 2, 3, you go 3, 2, 1. So it's more digits backwards to see how many they get. If they are allowed to get 1 mistake per increase in numbers. Then we have them do the years or the months of the year backwards starting in December. And then subsequently, we have them recall the 5 objects or 10 objects we repeated earlier. Then we do a balance examination, which would include a double leg stance, single leg stance, and tandem stance with eyes opened and closed. Some universities have a Biodex balance machine, which has a hard surface and a soft surface, which would allow you to do a preseason balance assessment. So if they are concussed, prior to them being cleared to return, making sure the balance is okay. This is an example of a Biodex report in which the one on the left is their pre-injury Biodex, and the one on the right is their post-injury Biodex, and it looks normal. And it's judging on both the hard surface and the softer surface. And then we score the CAT5 overall to give them an overall score of the SAC and also a symptom score to look at the progress of that concussion. This is our sideline evaluation card that we use. So you can see on here, there's no numbers, but I carry this in my pocket on BC football. And so if a student athlete has any concussion symptoms, so obviously there's a yes, no there, any amnesia, Bromberg, and we look at their pupils, do a SAC on them in the medical tent. And if they have any of those symptoms, we take their helmet and we take them out of the game, and then we reevaluate them every 5 minutes until their symptoms start to stabilize. So there's no same day return to play for athletes diagnosed with concussion. So then after you've diagnosed with a concussion, key features on follow-up exam, you really want a comprehensive medical and neurological assessment. So that include their baseline mental status, their current mental status, cognitive function, how they're sleeping, a good vestibular-ocular exam, because vestibular-ocular is often missed for concussion. That can lead to post-concussive symptoms and prolonged symptoms for concussion. Gait and balance exam, you want to monitor for improvement and deterioration since the time of their initial injury, and also determine the need for any emergent neuroimaging, i.e. if their exam changes from a concussion to something else. Concussions can be managed appropriately without the use of neuropsychological testing, and that's why we really recommend it, but not mandate it based on the previous slides. Neuropsychological assessments can aid in assessing the cognitive activity independent of symptom resolution. So we do use this, and preseason, our athletes do take what's called an impact test, which is more of a type of neurocognitive test, which is pictured right here. So you see here, baseline, it has a percentage next to it, and also a memory composite that's verbal and visual, also a visual motor speed component and reaction time component. Cognitive efficiency index tells you whether it's a valid test or not. All of our athletes need to take this test and pass this on par of their return to play progression before they go back to contact practice. So we don't use this as a sole decision making, but it's part of our decision making process from a final clearance standpoint. The biggest thing that came out of Berlin is that there's really insufficient evidence to support complete rest beyond 48 hours to enhance recovery. So after about 24 to 48 hours of rest post-injury, we encourage patients to gradually progress their activity level. So that's called subtherapeutic exercise or submaximal exercise. So it's not saying go back to running a 5K, it's just more doing 20 minutes of walking outside and monitoring your heart rate about 50% max exertion, which is 220 minus your age at 50%, which for a 25-year-old would be around 100 beats per minute. Typically, patients to refer to sports medicine would be those that are following sports-related concussion that have persistent symptoms past 10 to 14 days in adults and greater than 4 weeks in children. We're happy to see anybody prior to that, particularly if you have somebody who really wants to get back to sports or needed, but those are the patients that typically may have more of a prolonged course in their concussion management. You really need a detailed multimodal clinical assessment to identify both primary and secondary pathologies to see why they're not getting better. Also individualized treatment programs. So that individualized and collaborative treatment approach would be cervical rehabilitation, vestibular-ocular rehabilitation, the Buffalo concussion treadmill test, which is something where we're talking about using your heart rate as a guide and doing submaximal exercise while you're still symptomatic. It could be cognitive behavioral therapy, which would be for patients that do have behavioral medicine background or can't get past more the depressive state of the concussion. Could also be for school accommodations and what can they do in the classroom. We know that math and science typically struggles a little bit when they get back from concussion as opposed to the linguistics. And typically from a literature evaluation, hasn't really evaluated stuff prior to 10 to 14 days because most people have clinical improvement. We do add a lot of these modalities into our student athletes who are getting better but not symptom free, even prior to 10 to 14 days. Early symptomatic treatment, 24 to 48 hours of cognitive and physical rest, and then progressing. As we just stated, over-the-counter analgesics such as acetaminophen can be helpful for headaches. ADHD medications, migraine meds, and fish oil have mixed data as far as the symptom management. If you have ADHD prior to, you should continue your ADHD meds. You shouldn't start people on ADHD meds if they have not taken them prior to their concussion. And you also don't want to mask symptoms, but at the same time, if you don't treat a headache overnight with acetaminophen and try to get it down, then that patient's not going to sleep, and then they're going to be worse the next day from a symptom management standpoint. Neurobiological recovery could extend beyond clinical recovery in some patients. So there's currently data with the NCAA and Department of Defense where we're studying how people feel better, but their neurons still aren't firing. And predictors or slower recovery from a sports-related concussion could be initial symptoms are worse on post-injury day 1 or 2, subacute or pre-injury, mental health, migraine or headache history. ADHD or learning disabilities would be more so concerning for return to academics as opposed to a hindrance in return from concussion from a physical standpoint. And also teenage females have been shown to have prolonged recovery in literature. There's no current single definitive physiological time window for sports-related concussion recovery. Including post-concussion syndrome and et cetera, there's a wide array in the literature, but there's really no, we can't tell a patient when we expect them to get better. It's really individualized treatment approach. And then once a concussion symptoms have resolved, there's gradual stepwise progression back to activity with each phase spanning at least 24 hours. If somebody has worsening symptoms during that progression, we pause them, wait till they're symptom free again, and then revert them back to the previous step on clinical return to play progression. So the return to play progression, if they're still not symptom free within 24 48 hours of we progress to the subtherapeutic exercise, but once they're symptom free, typically day 1 is light aerobic exercise like a bike. Day 2, after 24 hours, provided still symptom free, sports specific training. The next day would be non-contact training drills. Then after they complete that, we would have them do their balanced check and also their neuropsychological testing with impact. And then we'd progress them to full contact practice after medical clearance, and then return to competition or gameplay. You shouldn't really return somebody to gameplay. It should be to full contact practice to make sure they tolerate contact okay first, just because of the higher incidence of gameplay related concussions versus the practice related concussions. And then as far as reconsidering, all athletes, regardless of level of participation, should be managed using the same management principles. And children and adolescents should not return to sport unless they have successfully returned to school first. But that does not exclude symptom-limited physical activity, which is appropriate for their return to play, similar to the buccal concussion treadmill test. The NCAA Department of Defense Grand Alliance Care Consortium, I've had the privilege of attending 3 of these conferences so far about research on biomarkers and also enhanced neuroimaging in order to screen how we can do concussion better, or how we can diagnose this better, or how can we predict the CTE, the other repetitive concussion injuries. But all that is part of a 10 to 12 year study in which they're collecting data at multiple division in schools and also the military academies. So in the future, is there a minimum timeout for concussion because of the potential blood biomarkers with the NCAA Department of Defense data? We really want, it's hard to get double-blinded prospective studies because of the manifestation of concussion. We continue to validate our current assessment tools, and we want to delineate the role of neuropsychological testing further. So our big take-home points, if you missed any of this: insufficient evidence to support complete rest beyond 48 hours to enhance recovery. Concussions can be managed appropriately without the use of neuropsychological testing. There's no current single definitive physiological time window for sports-related concussion recovery. Children and adolescents should not return to sport unless they have successfully returned to school. And most concussions require an individualized treatment plan and clinical approach to recovery. Here are my references. And again, in case you missed it at the beginning, our sports med team at 978 Newton-Wellesley Sports Medicine includes Drs. Foster, Nascimento, Simon, Rogers, and myself. Orthopedics, surgery, sports medicine, shoulder. I specialize more in primary care sports medicine and do concussion management and also osteopathic manipulation and any other non-surgical endeavors. Cool. Thanks.
Thanks, Doug. It's John Snyder back here. That was really great. A nice little brief overview. There was one question Sally was asking, like everything else, the CAT5 looks really useful. It would be way more useful if it was in Epic. Any word on that, or have you seen that, or is there any talk about that?
We can try to upload that into an Epic and build an Epic tool to put a symptom score in. I typically have my own smart phrase for concussion and just add in the numbers manually. But if we can build, we can try to build that through the Epic team.
Yeah. Okay, that sounds great. What about the? I wanted to ask about the impact testing the same way. Two questions about that real quick. One is the impact testing. Is that something that you do on all your athletes, and would you recommend all high school athletes getting it done? And then two, I've certainly heard anecdotally, especially in the high schools, a lot of kids like to dumb down their impact at a baseline. Have you seen any of that so they can get back to play faster?
We've seen it, but the funny thing is that I think that student athletes are more nervous about getting concussions now than they were 10 years ago when I started at BC. So back 10 years ago, the seniors would tell the freshmen to dumb it down, so then that way they could get back quicker. But now I think student athletes and their parents are a little more concerned about actually brain injury as opposed to playing in their sport. And also a lot of our student athletes now have taken some form of neurocognitive testing in high school before they matriculate to school. What we do, the NCAA mandates some form of concussion screening. So we impact all of our contact collision athletes, and we do a SAC or symptom score sheet on patients for baseline for like golf, let's say, because unless you get hit by a random 9-iron or a ball, you're not at higher risk for concussion.
Right.
But we do the neurocognitive testing at the beginning of their freshman year, and then if there's more data now to say to not repeat it annually, because it used to be done annually, and now we just would that's their baseline test, and then we would screen them again, and then once they clear, that's their new baseline test.
Okay.
And as far as high schools, a lot of high schools do have impact contracts with a lot of high schools, but the only bugger is that they don't have anyone to interpret it in the high schools.
Right. So I was just going to ask about that. So frequently in the office, as a family doc, we're asked to either interpret that or to say that this kid can return back to high school sports. We weren't on the sideline during the injury. We're getting a history from a kid who wants to get back there. It does become a challenge for us. The 48 hours is news to me, so I'm glad you kind of put that out there. But how do you deal with with the kids where you're not so sure if they're actually going to tell you their symptoms are free or their symptoms are not, and you're worried as their physician about further brain injury? That's for sure.
Well, I think then that's why I put on there about how neurocognitive testing is only a piece of the pie. So I think impact and other neurocognitive tests like to have it as the center of the pie. But what we really need to do is make sure these kids are symptom free, and they also need to do a return to play progression. So I think that particularly if it's a high school individual or a local high school kid, you want to make sure they have an athletic trainer at the high school who can actually help manage that return to play progression. So that's the first question I would typically ask. And then if they don't have an athletic trainer, have them, just at least instruct them that they have to do a return to play progression, that having this impact test does not actually clear them to return, because you need to make sure that they don't have symptoms if they simply go on an exercise bike.
Right. That's the point. Yeah.
Yeah. So typically it's a 5 to 7 day return once you are symptom free. So yeah, that's the key.
And then, I know you're dealing mostly with college athletics, but again, a lot of us are dealing with high school and also weekend warriors. So, what do you tell about the academics and about work? You said 48 hours, get out of bed and start moving. So frequently, as you know, when they start to concentrate at school, especially this year with Zoom school, and then, in general at work, when a lot of things are on Zoom, they get frequently symptoms come roaring back. How do you kind of counsel your patients on that?
Yeah, so that's where you really need a good vestibular ocular evaluation. So seeing how much lateral gaze they have, see if they have symptoms in certain movements. I'd make sure to give them, especially if it's somebody who works on a computer all day, or basic Zoom classroom kids. We would make sure that they know how to do their home vestibular exercises, which involve a popsicle stick and eye movement, and then making sure they do that not right before they go on the computer screen. So for workers, what we do is once they're stabilized from a symptom standpoint, we would have them go on their computer screen for 10 minutes on, then 10 minutes off, and then see how that goes. And then we would clear them to return for a 3-hour day first. And then, and typically for concussions, I would reevaluate somebody every 2 weeks. So that's sort of the moniker where, particularly in a workers' compensation, or even somebody who got an injury on a non-workers' compensation, where it's they're struggling in return to work. You just want to progress them slowly, depending on how they're recovering. From a student perspective, it depends on. So from college level, they have learning resources and disability services. So when I was at BU previously, I worked directly with disability services and had the concussion intake forms so that we could fill those out for them. For Boston College, the same way we work with disability services. In high school, it'd be more of the guidance counselors and the school
Sure.
nurses. And then different towns have different policies for return to learn. Some towns, if the student does have symptoms, then they would pull them from the class. But we would try to give them screen time on than screen time off. A lot harder to do right now via Zoom, but hopefully now that everyone's going back to school live, we hope,
Yeah.
then it would be a little bit better.
Excellent. Doug, thanks for a really great talk. And as you know, I said in the beginning, Doug's fully trained family medicine at Tufts University there. And he's also the lead physician at Boston College, as he has a sports medicine fellowship. And he's also available to see your patients at 978 Worcester. So Doug, thanks again. Really appreciate this, everyone. Happy April 1st. I just heard that opening day was postponed till tomorrow. So don't play hooky today. You can play hooky tomorrow. And we'll see everyone next week. Next week, we have a great talk about incontinence with Dr. Coley. Everyone have a great weekend. Thanks. Thanks, Doug.
Thanks, John. Take care.